We're going to go on now to urinary incontinence or urinary catheter presence. Now, they greet you at the door, and sometimes you might be greeted by someone who's carrying a Foley bedside drainage bag. But again, a lot of times people, with urinary incontinence are very embarrassed by it. However, you can assess for any odor in the house, or you can smell any odor. And for some long-standing incontinence patients who may not be able to do housekeeping tasks, odor can be quite prominent. Incontinence impacts, again, a lot of the functions of people across the ADL spectrum. So the importance for care planning can be caused, what you need to look at for care planning really need to focus on any urinary issues and or ambulation issues. So you want to be concerned if you do smell odor, the physical cause for that odor, the risk for skin breakdown. We're now getting into integument. If they are incontinent, what does their skin look like? And are they both bowel and bladder incontinent or just bladder incontinence? There could be a difference there also. Again, bowel incontinence. During ambulation, you can assess for this. Again, it's important for care planning, the comprehensive assessment. You want to be concerned about physical causes. I would believe that if the person is bowel and bladder incontinent, they are at a higher risk for skin breakdown than if they are just bladder incontinent. Both are a risk. So we need to look at that. Now again, remember, we've just greeted them at the door, but we see how they cognitively function usually. We can nurses have a great ability, I've seen over the course of time, to really understand where a person is on a scale. If there are cognitive issues, is it beginning? Is it a mild? Is it a moderate? Or is it a severe? During the day of the assessment, we want to check their level of alertness, their level of orientation, their comprehension, their concentration, and immediate memory for simple commands. And this is very easily done during an assessment or a reassessment visit. You can look at their conversation with you. You can look at their caregiver's conversation with you also. So all the different issues, they could have dementia, they could have delirium, maybe caused by an active infection. They could have developmental issues, mental retardation. They could have had a stroke. They could have had some mood or anxiety disorders. And all of the above can carry some degree of cognitive impairment along with that disease diagnosis. We have to determine, the amount of the cognitive impairment. So again, the safety piece, how do they care for themselves, how much supervision is needed, can they access emergency care? And again, our education and teaching now really starts to come in. How much can we educate? Will it be absorbed? Do we have to educate the caregiver? And is this who we focus on? So those kinds of issues start to percolate at this point in time. Again, 1710, when the person is confused, reported or observed within the last 14 days. Assess during conversations and input from the patient and or caregiver. This particular question pertains to the 14 days preceding the start of care, so that we want to look at the 14 days preceding, not a month back or maybe 2 days ago this started. Then you have to start to think about other things. So 14 days preceding, is the person confused? Again, it's the same piece of importance about their ability to care for themselves, or if not, who is going to care for them or supervise them. If they're anxious, a lot of anxiety is, I believe, to be underscored and overlooked. And it is, I can understand why, because if, I think of it, if that you were in a patient's shoes. something has happened to you, you've had an event that you are eligible for skilled, intermittent, free, reasonable and necessary services from a home care agency. Well, that in and of itself means that you've been ill and that you need some services because something happened. You are anxious when these things happen. So we want to look at the person's anxiety level. Now, some people are anxious all of the time, and this puts another overlay on their anxiety, and it is heightened to a point that they can become much less functional and sometimes non-functional. So really look at this anxiety question and answer it as accurately as you can through your observations of the patient. And anxiety in and of itself really does impede the ability of the patient to absorb any information or education. They usually have to be retaught, it has to be redemonstrated, and so on and so forth. So it does impact on different things. It impacts on their ability to do things, but it does impact also on their ability to progress as rapidly to goals as we would see in other people who are not so anxious. I think their timeline is lengthened out. So under ambulation, we watch them walk. See if they are safe. Remember, the functional questions go to the safe ability of the patient, not the ability of the patient to do it. It is the safe ability of the patient. Now, I have, an example that I give for this is that when I have a patient, I'm looking at the functionals, I have them take off their shoes and socks. I watch them bend over. And a lot of times, they can't do it without assistance because they are unsafe bending over. So that makes me change my answer to the point that they could do it to the point that they need assistance doing it. And there is a line that's there. I mean, I've seen people, they could go tumbling forward off the bed and onto the floor or wherever they're off the chair and onto the floor because they're not safe bending over. So it's very important to think about the safety piece. And this is where I believe that nurses have issues, that they look at the person's ability to do it, and yes, they can do it, where it's the safe ability. If you can get anything across to staff in teaching, safe is the imperative word in the functional ADLs of the Oasis. So we want to see how the person walks. Some people walk very well on wood, but they drag their feet or have some form of foot slap or foot drop, so they get caught on carpeting. So we want to see how they walk on all different kinds of surfaces. We want to see if they have stairs outside or inside of their house. And if they do, if they have stairs inside of their house, what's upstairs? Is the only bathroom in the home upstairs, or do they have a bathroom on the first floor? So very important in the elderly in terms of how many times a day do they go up and down? Are they safe to go up and down? And physically, can they go up and down the stairs more than once or twice a day? So again, we're now going to review home care. We're on the third step. We want to review home care insurance and all the consent forms that we have, which are, substantial. So we, of course, sit down with the person at that point in time. We explain our agency, and we want to talk about our services, and we want to talk about the person's insurance coverage. We need to review consents with them and have the person sign for the services that we're going to give to them. And again, we're going to begin to develop the plan of care. Well, I put in here in parentheses the patient's expectations and the clinician's realism, because sometimes the visit gets held up a little bit here, where the patient may have been told incorrect information in the hospital or in the doctor's office that, yes, someone's going to come to the house and they're going to be there 3 or 4 times a week, and they're going to stay for a long period of time, and they're going to come for many weeks. Well, the realism is that that might not be true, and more than likely won't. So we have to temper this with our plan of care, what's going to be the frequency and duration, what is reasonable and necessary, and what services are we thinking about putting into our plan of care at this point in time. And again, we're continuing to assess all of those M questions as we go along and interact with the patient. Again, with vision, we go back to the vision question. We assess vision while getting consent signed. Does the patient require that you point to the signature line? They really can't see the line. What about newspapers? Can they read newspapers? Or, as I did before I got glasses, my arms were not long enough to read anything. So again, we ask if the patient uses corrective lenses. And this was one of the most incorrect answers over time that we've seen in the data that we collected, and that's vision. The nurse or the therapist who was doing this thought vision was vision, but didn't read the question as with corrective lenses, so they marked them as partially impaired if they needed corrective lenses, which of course was not the intent of the question. It is much better now through a lot of education on the part of agencies. So if the person uses devices, whether it be prescription glasses, readers that you could buy in the store without a prescription, and does the person use magnifying lenses? There are still some people who use magnifying lenses, but they're not considered corrective lenses, magnifiers. Store-bought reader glasses are. So that if a person does not have corrective lenses or store-bought readers, but uses a magnifying glass to read the paper, you would answer this question, M1200, as partly impaired, and then part of your plan of care would be to get the person to coordinate ophthalmological care or an optometrist and get the person for an eye examination and perhaps getting prescription glasses for them. And you want to see, could the person comprehend the consent? Now, again, don't read the consent because legal language is beyond the grasp of most people, most patients, sometimes even beyond my grasp. But again, we want to make sure they understand what they are signing for. They understand that they're authorizing us to give treatments to them. It could be that we could take pictures of them. Notice of privacy practices are in there. Authorization for release of medical information. All of those things we need to explain to the patient and make sure that they comprehend what it is. Now we're finished with that piece. We're going to step number 4. So we're going to walk, the patient is going to walk to where the medications are kept, and the nurse and the patient review the medications together, interaction. So you can ask the patient to show you where the meds are kept, and you can ask the patient to tell you about, can they read the medication labels, and once they read it, do they know what that medication is for? And a lot of patients are very creative this way. They may not know what the medication is for, but they draw a picture on the bottle, a heart, so they know it's their heart medication, or they write BP on the top of the lid for their blood pressure medication, that type of a thing, and that's fine. That shows me that the person is really pretty cognitively intact and creative, or that the caregiver does understand if they have to give the medications or pre-pour the medications, what each medication is for. Is there any kind of medication list in the house that they take? People are getting more, I think, astute these days. I do see in documentation that I review, a lot of times there is now a list of medications that the family carries or the patient actually carries with them in case something happens. There's a list of medications in their wallet so that if they need to go to emergency room, someone can get this from their wallet. Is there a pill box? Do you see a pill box there? That may alert you to the fact that The patient may need their medications pre-poured for them, or they may be a little confused about their medications, and again, it affects your education and your teaching thoughts about how to educate this patient on their medication and compliance with medications.